Hi, David, Claudia.
Dr. Naghavi, welcome.
Thank you. What a wonderful session. Thanks for waking me up at 2:30. It is definitely an honor to present to such a group of pioneers. You guys have built a way, and I want to just start by acknowledging really a legendary in your team. When I saw this slide, it was just really an eye-opener. 36 years ago, this is Claudia's picture in her slide that I borrowed. And I didn't know about this when we honored her for her 30 plus years of pioneering work in lung cancer prevention in this by highlighting this New York Times article. When it comes to lung cancer, she doesn't believe in waiting. We really just started putting our feet in her footsteps. And I want to acknowledge also David's visionary view of where I am now. It was like 4 years ago when he was telling me, you really need to look into it more. I kind of brushed it off at the beginning, but I think connection with Tony, who's really our AI brain, paved the way to where we are. So I'm going to just quickly walk you through. This is going to be a NASCAR ride to 60 slides in less than 10 minutes. So what you see here, my team who contributed to our first development in AI work, what David refers to and you guys as bonus finding. But it is also on the back of about 20 years of work I did starting SHAPE, Society for Heart Attack Prevention and Eradication, which led the effort to pass the first heart attack preventive screening law in Texas, HB 1290, that pays up to $200 for preventive screening, including coronary artery calcium score. SHAPE is similar to the Cancer Prevent Cancer Foundation and the pioneers behind that. And I want to acknowledge Dr. Molstein's talk. It was just fantastic. I've loved listening to his presentation. So what are we about? Early detection. And this is, I borrowed from David, which is really sad, but we in cardiology are not far ahead in identifying the disease before it becomes symptomatic and too late. In our analysis, I would bounce some of these to Bruce, who is really brained in statistics and analysis of Medicare data, but about over 50 million people would need to be screened for us to do our job. And current number is less than 1 million. So this is our vision, built in collaboration with Claudia and David and Tony and others, that we think we have about 10 bonus findings coming out of a CAT scan or a lung cancer screening scan that we could have actionable reports from. These three that are highlighted, fortunately in Texas, we have reimbursement for those, as I said. And in years ago, about 2010, I edited this book, Asymptomatic Atherosclerosis, and did a great job. Leslie Shaw did a great job of doing analysis showing that we can actually, just by the calcium component of it, these are numbers, of course, assumptions, but numbers that others use for modeling, about 20 billion in saving for healthcare. So we went with the lowest hanging fruit, again, working with Claudia and David and Matt Budoff to get the first FDA approval for automated bone mineral density reporting in the same scan. And this is done based on trabecular bone isolation. I have to credit Bob Bertrano's work back 2004-5, where he published that we can get this data from CAT scans. And Matt Budoff and Dr. Mao, Matt is the leader of the team, published quite a few things, even got a SBIR grant to try to push this to commercialization. And I was successful at it to finally, pass the baton to us. Bone density, low bone density is a serious problem despite so much improvement in our, dietary input and all other exercise and so on. You look at the last 30 years, 111%, this is WHO report, increase in fatality. I'm not talking about hospitalization, fatality. This is Matt Budov's slide. Women have more osteoporotic fracture than heart attack related morbidity and mortality. That is an eye-opener. So our AI basically identifies the vertebral body, goes to the trabecular bone, calculates the average of Hounsfield unit, removes the Hounsfield units over 400 or 500 HU that are not really trabecular bone, those are sclerosis, and plotted against a very, so this basically shows you validation in about 10,000 patient population, Harvard, UCLA, and plotted with manual against manual measurement. Of course, you might say, well, manual measurement of that is not the standard of care. The standard of care is DEXA. You're right. It's unfortunate, but you're right. So we correlated with DEXA Warts triangle and showed a reasonable correlation. We have our belief that 3D CT has more information than DEXA, but we were able to show that to the FDA. We also were able to show correlation, good correlation, with non-gated lung cancer screening cases versus cardiac calcium scoring cases. Manual, cardiac in the middle, lung on the right side. And you can see in the full thoracic, you would need to go around T7 to T9 to get a good correlation with cardiac. So we zoomed on these as or a standard tool. And you can see the difference is very minor. It's not even detectable. Very good correlation, again, in lung versus cardiac. How does it work? It's pretty simple. We try to make it simple that scans, existing scans or scans that are ordered for other reasons, go through the gateway, anonymized, comes to our AutoBMD AI. The data within 2 minutes come to the provider's station, also is shared with patients through their app for convenience. And this is currently available for a period of time for free. Everybody can try. So where we started was coronary calcium, as I said before. This was, again, credit to David. Particularly, I remember this at RSNA, he was pushing me to look into that. And this auto chamber really uses non-contrast CT scan, trained by contrast CT scan, to measure or estimate the volume of cardiac chambers. At the beginning, we were just literally looking at LVH, the most commonly studied component. But soon we realized that there's a lot more information by looking at the chamber volume. So we converted, we got approval from MESA to compare it with MRI. We showed a very strong, reasonable correlation. We then took it to non-gated versus gated, to my surprise, a very strong correlation, R squared 0.93 between a gated cardiac and non-gated. And I'm just showing you one, but all of the chambers are around 0.9 for gated versus non-gated. Then thanks to Dan Levy, director of Framingham Heart Study, he pushed me to do a comparing with echocardiography. Again, we're talking about a bonus finding of a CT scan done for lung cancer or calcium scoring. As you can see, it's beautifully separating the HFrEF, heart failure with reduced ejection fraction, with HFpEF, heart failure with preserved ejection fraction. On the left side is a bonus finding of a cardiac CT scan. On the right side is our beloved regular echocardiography. We then showed that if you look at the outcomes, in this case, 5-year AFib, atrial fibrillation, this bonus finding, based on measurement of LA diameter, LA volume, does a much better job of detecting who will have atrial fibrillation versus the standard of care today is charge AF. It's a risk score. Years ago, I started this project and I ran for the competition by Google and AHA, one brave idea. They put $25 million. We didn't win, but I rallied a large group of people. What if we can use AI to detect risk of heart disease, meaning heart attack, a coronary event, within 12 months? And so I made the analogy of detecting, 10-year risk, 20-year risk versus, a few weeks and months, like the hurricane prediction. Imagine if the weatherman would tell you in 10 years you have a risk of catastrophic hurricane in your area. Nobody would show off their window or do anything. But if you tell them in next week, this will move and people would be walking away from the eyes of hurricane. So this is our first fruit from that effort that was just kind of surfaced that we were able to show in 1 year follow-up. Again, bonus finding from a CAT scan, those people who had the stroke with our method, auto chamber, versus, of course, CAT scan doesn't have anything. Now, compare it with charge AF and BMP for AF prediction, that very bonus finding did, at least by numbers, 0.83 versus 0.77. Sample size is only 34, so it's not significant. At 5 years, LA volume alone, 0.78, BMP plus charge AF, 0.78, not significant, both the same range. This is very interesting. It tells you, doesn't matter which risk categories of calcium score you are, you're still picking up a sizable people by looking at LA volume quartile. This is the top quartile, middle, third, second, and bottom quartile. Here is the bottom line. We think we add value to a CAT scan, hopefully the same way we will show by, we haven't done this for lung cancer screening cases enough because MESA is baseline and are all gated. All of these are NRI, net reclassification improvement. I bring your attention mostly to stroke here because these are the people who wake up, had no idea they had AFib. This is David's passion. He really pushed me on this, that they had friends really experience it in their life with a stroke. Well, look at our NRI, 0.88 over CAC. So I think we have some real example, real life example. These people came for a CAC scan, both patients, 51, 52-year-old, both negative calcium scores, so 0. What would we do in cardiology practice? We give them open as champagne. You're clear. Well, both of them died a few years later, one with a stroke, one with heart failure. And if you had put them on our auto chamber, look at what we found. 99 percentile, LA volume 120, LV 338. The average is 120 in the population. So these could have been saved by David's idea. And this is some sort of a sample report that we hope FDA will approve in a few weeks. We've had several discussions with FDA. And I'm just going to wrap up with our long-term vision, hopefully not too long like Claudia's 36-year-old visionary work. This is hopefully next 36 months. We will bring this to neighborhoods in front of Walmart's, Walgreens, and Kroger's, and Target, and we'll be able to do not only cardiac and lung cancer screening, also add a blood draw like the Gallery test, which your panel beautifully presented on liquid biopsy, and bring to people what really needs to be there is healthcare screening, where they go to do their weekly grocery with 7 minutes in and out to get their screening done. And hopefully we send them home with some personal healthcare monitoring devices. Thank you very much, David and Claudia, for your awesome work, and I'm glad to be part of your work.